Hello, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are the Oncology Brothers. In the year of 2023, we saw more than 40 new drug approvals or indications in oncology, out of which 3 were in hormone receptor-positive breast cancer, sacituzumab in refractory settings, and then Elestrin for ESR1 mutation, and Capivasertib for PIK3CA, AKT1, and PTEN mutation. Previously, we've covered Elestrin with Dr. Kaklamani. Today, we're joined by Dr. Hope Rugo again to unpack the data and to better understand the approval of Capivasertib based off her study, CAPItello-291. Dr. Rugo, thank you so much for joining us.
It's a pleasure to talk with you today.
Dr. Rugo, welcome. Just to set the stage, where we stand today for hormone receptor metastatic breast cancer patients is we start off with endocrine therapy with AI. If there is progression, then we tend to rely on PIK3CA mutation. If that is present, then alpelisib plus fulvestrant is a choice. If ESR1 mutation is present, then elacestrant is a choice. If germline BRCA mutation is present, then we tend to rely on olaparib. Now, with PIK3CA mutation, AKT1 mutation, and PTEN alteration, we have a choice of capivasertib plus fulvestrant. And that's what we are here to talk to Dr. Rugo about, which led to the approval of capivasertib in November 2023. Dr. Rugo, can you share a little background on how we got to CAPItello-291 from faction and then, of course, the study design?
Absolutely. And I will say that the one thing is that to add to your very nice sequencing is that we use CDK4/6 inhibitors, of course, now in the first line setting. And there's a little bit of a sort of intermediary time here where indeed, if you have a PI3 kinase mutation or a mutation in the pathway, you have options to give patients in combination with fulvestrant, and ESR1 mutations play a role, but we're also waiting for data on whether or not giving a CDK4/6 inhibitor after progression on a CDK4/6 inhibitor with changing the endocrine therapy partner might be another effective strategy. So there are certainly a lot of things in the mix at the moment, and we're exploring triplets of the agents that block the PI3 kinase pathway along with CDK4/6 inhibitors in endocrine-resistant disease. So CAPItello-291 really developed out of data from a phase 2 study, but also Capivasertib came from the laboratory actually in the UK and was then developed by the pharmaceutical industry after showing promise with an intermittent schedule given 4 days on, 3 days off with very tolerable safety. So an initial phase 2 randomized trial called FACTION where Capivasertib was added to fulvestrant compared to fulvestrant in a population where not everybody had CDK4/6 inhibitors, but it was given in the second line setting after progression on an aromatase inhibitor, showed remarkable improvement in PFS and OS. And this seemed to be regardless of the mutation status of the tumor. So we were very excited about that, and the tolerability of the agent was quite good. And that really led to the design of CAPItello-291. So the way CAPItello-291 was designed was to enroll patients who had had progressive disease with hormone receptor-positive HER2-negative metastatic breast cancer after 1 or 2 lines of endocrine therapy. They were also allowed to have up to 1 line of chemotherapy for advanced disease, which not all of these studies have. And even with small numbers of patients, you do tend to enroll a patient population with more resistant disease. Patients were allowed to have prior CDK4/6 inhibitors, and at least 51% were required. That number is going up as CDK4/6 inhibitors, of course, become more of a standard of care around the world, so that it's certainly somewhere in the 60 to 70% or higher range now in the newer studies that are being developed. You couldn't have had any agent, of course, that affected the PI3 kinase or AKT pathway and no prior SERD because the partner was fulvestrant. And then you could have recurred within 12 months of or while on your adjuvant therapy, so-called primary and secondary endocrine resistance, and that would have counted as 1 line of endocrine therapy. Because agents that target the PI3 kinase pathway as a pathway effect are known to affect glucose metabolism, we needed to have some kind of requirement for glucose control. But capivasertib in the earlier trials really hadn't resulted in much hyperglycemia. So we allowed patients with a hemoglobin A1C up to 7.9%. So patients could have had frank type 2 diabetes or pre-diabetes, and those patients were allowed on the study, which is not true of the other studies. Alpelisib had a slightly stricter control up to a hemoglobin A1C of 6.5%, and a recent study with a novel PI3 kinase inhibitor, inavolisib, really had patients who did not have much abnormal glucose metabolism at all. They had pretty much all of the patients had a normal hemoglobin A1C, so that's important to keep in mind. Of course, the randomization was 1-to-1, slightly over 700 patients, capivasertib versus placebo with fulvestrant, with the overall endpoint keeping in mind this prior data, so progression-free survival overall, but also in the AKT pathway altered tumors defined similarly to FACTION. So you could have had a qualifying mutation in PIK3CA, AKT1, or PTEN, which is normally PTEN loss, that was evaluated in tissue, because there aren't really well-defined ways of evaluating PTEN loss that are felt to be reproducible in the plasma looking at ctDNA. And then, but you could do ctDNA as well, but they did require one of these to be abnormal in tissue, and then overall survival and overall response rate. So that was the whole design of the study, and it actually accrued fairly rapidly, so you could enroll whether or not you had a mutation in your tumor.
Dr. Rugo, thank you for going over that. Before we even go any further, how prevalent is AKT1 or PIK3CA PTEN mutations?
That's a great question. So any AKT pathway or PI3 kinase pathway alteration occurred in about 40% of patients in CAPItello-291. And it was interesting, the split, any PIK3CA mutation or PIK3CA mutations only were seen just under 30%, about 28%. But if you looked at the combination of different mutations, looking at AKT1 only, PTEN only, which were in the 5 to 6% range, and then combinations of mutations, which are generally in 1% or less range, altogether it ended up being about 40%, which is what we would have expected. There were some patients where the tissue just wasn't adequate to look at for mutations, and that occurred in 16% of patients in the capivasertib arm, and about 14% of patients in the control arm. And the plan in the future is to be able to look at blood, so ctDNA, to define those pathway unknown alteration patients. But that hasn't been done yet, mainly because of trying to validate the PTEN analysis in blood.
Thank you again. Now, 40% is not a trivial number. The other thing I want to reemphasize here, what you brought up, was the dosing schedule. This medication was given 4 days on and 3 days off while we continued with fulvestrant. Dr. Rugo, you've mentioned ctDNA. I promise we'll get to the results, but what is your workflow right now to look for these mutations?
So my workflow generally is to, if I know I'm giving a CDK4/6 inhibitor in the first line setting for a patient who doesn't have primary or secondary endocrine resistance, I won't check immediately. But if we've done a biopsy to establish metastatic disease, we'll generally send NGS then. It's covered within a month in California after the biopsy, so that's one motivating factor. And then we do ctDNA when patients are suspected to beginning to have progressive disease, and that makes a really big difference in terms of planning for patients, looking for clinical trials, and talking to them about next steps. As long as a patient has endocrine sensitive disease, I will check a ctDNA on progression just to see what other options I have. Of course, I'm also looking for somatic mutations in HER2, in BRCA, other types of targetable mutations, although I have to say they're relatively limited in breast cancer.
Absolutely. Thank you. So now there is a potential mutation that we can target. What did this study show?
Well, of course, we've been targeting PIK3CA mutations with alpelisib, but we've been really challenged with the toxicities of alpelisib and the fact that, something like half of our population in the United States, and in some countries even more, have some abnormality in glucose metabolism. And then there's also can be a significant rash that limits treatment and long-term diarrhea. So we're really excited to look for another agent that might have a different toxicity profile to see whether or not we could improve outcome. And in fact, adding capivasertib to fulvestrant improved progression-free survival by almost doubling it from 3.6 to 7.2 months with a hazard ratio of 0.6, and that was highly significant. But of course, we looked at this 40% of patients who had alterations in the AKT or PI3 kinase pathway, and there the improvement in median progression-free survival was just a little bit better, going from 3.1 to 7.3 months with a hazard ratio of 0.5. So you see a little bit of improvement in the hazard ratio. You can see that there's this initial 20% of patients, if you look at the overall population who have some progression by the first scan, that seems to be a little bit less when you focus on the AKT pathway altered tumors, a little bit less of that early progression showing very immediate resistance to endocrine therapy, which suggests that those patients may be benefiting even more than the patients with the AKT non-altered or wild type tumors. We did look at, and I think that this is important, for the regulatory purposes and as an exploratory analysis, we looked in the non-altered population. We included that 15% or so of patients who have unknown mutations in that unknown population. Now, some of them, of course, could have mutations, but the PFS difference was very similar. They are going from 3.7 to 7.2 months. But we've gone down now in numbers of patients, and so the hazard ratio is just 0.7 in that group of patients. So I think that that's what led the FDA to say, until we have more information, we're going to just narrow the approval to patients who have alterations in AKT, PI3 kinase, or PTEN.
But that's still pretty remarkable, especially when not having the mutation and having such responsiveness. Now, since you mentioned that having another option, especially when you talk about the hyperglycemia aspect of it, which we were dealing with alpelisib, this is certainly a good option with no or less hyperglycemia concerns, where diarrhea certainly stands a major concern here. Now, if ESR1 mutation is present, then we have a choice of elacestrant. If we have a co-mutation of AKT pathway with ESR1, what do you really pick under those circumstances? And exactly with the co-mutations, how often do you see that with ESR1?
Well, so I think there's two parts here, the safety, which we'll talk about in a little bit, but I think that's an important question too about how we assess safety. But then sequencing, which of course has been a big issue. There's only maybe 20% of our patients or less who have co-mutations in ESR1 and PIK3CA or AKT or PTEN loss. And so it's not very frequent compared to when we see both of the mutations, which occur over time and up to 40% with ESR1, as I mentioned, 40% for the AKT pathway. So I think that, we are faced with that, but it's not as frequent as just seeing the individual mutations. I think that, we obviously in the metastatic setting, overall survival trumps everything except for safety. But we don't have overall survival data from elacestrant, and we don't yet have the final overall survival or even protocol specified next overall survival analysis for CAPItello-291. So that's not really going to be a driving consideration. In this situation, I think it's going to be just side effects profile and how patients are managing their treatment. So it's easier to take elacestrant than to take a combination. So if all else is equal, I think with the combined mutation, generally we'd start with elacestrant, where there is data that it seems to be effective in patients who have both mutations, although the numbers are very small in the EMERALD trial. And then if you have just the PI3 kinase mutation, of course, that's very straightforward, but you can sequence after giving elacestrant and give fulvestrant and capivasertib. I think we're going to need real world data to really understand how effective this sequencing strategy is, but generally that's what people have been using.
Dr. Rugo, thank you for covering that. Rohit, you and Dr. Rugo, you've mentioned about safety. Coming back to alpelisib, the uptake just in the community has been really low because of the safety there, hyperglycemia, diarrhea, rash. And it looks a whole lot better with capivasertib. Can we take a few minutes to dive into some of the side effects and Dr. Rugo, how to manage these side effects in our day-to-day clinic?
In Capitello, only about 9% of patients stop due to toxicity. But remember, it's 4 days on, 3 days off. So if you had a little bit of diarrhea, then you could, make sure a patient was taking an anti-diarrheal agent, but then they have their 3 days off, so they get better. And we saw the same thing with rash, where, we just really didn't see rash being a big issue for the majority of patients, even though, overall, about 9% of patients had grade 3 diarrhea and about 12% a grade 3 rash. And then it's also interesting that dose reduction seemed to have really played a big role. About 20% of patients dose reduced capivasertib compared to 2% for placebo. So that actually helps too. Another factor that I think is important for us in clinic is how quickly you get these side effects. The median time to onset for diarrhea was about 8 days. The range went out to about 3 weeks. And the rash about 2 weeks, with a very narrow range, interestingly, 10 to 15 days. Now, hyperglycemia also was, something of big concern. As you mentioned, we only saw grade 3 hyperglycemia in 7 patients out of the 355 who received capivasertib. And there was that same toxicity in 1 patient in the placebo arm. So very low percent, under 2% if you subtract the placebo group. 1 patient also had grade 4 hyperglycemia. That particular patient actually did not stop her capivasertib, which of course has resulted in a lot of interest in education in patients. But that was 1 patient, and she just kept taking the capivasertib for 3 weeks and had underlying glucose metabolism issues. So she recovered and actually went back on drug and tolerated it well. So the hyperglycemia overall, any grade, was only 17%. So that's very manageable in our patients, particularly given the fact that we allowed patients on who had significant issues with glucose metabolism. And then lastly, almost all of the drugs we give now, these small molecules, cause some degree of aphthous ulcers, similar to what we saw with everolimus, but generally at lower grade. And steroid mouthwash makes them go away right away. And those stomatitis occurred in about 14.5% with the CAPI, but it actually occurred in 5% with placebo. So overall, it's under 10% of patients who get any grade stomatitis, and it's all mostly low grade, so very, very easy to manage. The most common adverse event that led to discontinuation is rash. So I think it's important to tell patients about the rash and diarrhea and to help them with management before they start. So I start everybody, because I did this with alpelisib, with a non-sedating antihistamine agent, and that works really well. I have them take it twice a day, even though the label says once a day. 2 and even 3 times a day is quite safe, really just causing dry eyes and dry mouth. So they start it before they start the CAPI and then continue it. And depending on whether they get a rash or not, whether or not you need to dose reduce, you can actually just continue a lower dose of the antihistamine throughout the course, and that works really well also. So, you just have to sort of manage these individually with the patient and start out with good education. It's important, patients who have significant side effects to dose reduce. You can always go back up again if you feel like, you jumped the gun too quickly. But that works really well, both education, prophylactic strategies, management quickly, and dose reduction as needed.
And again, we've brought up using low dose in certain patients. That step down is 320 milligrams twice a day for 4 days. And there's another step down, which is 200 milligrams twice a day for 4 days and 3 days off. Dr. Rugo, any utility in starting low upfront in a certain patient population?
We have talked a lot about whether we should start low for some drugs in certain patients. For example, in the truly elderly patients, over the age of 75, in drugs that cause bone marrow suppression, we see more bone marrow suppression. We see more higher grade adverse events. So in that situation, if you're starting a drug that has, relatively narrow therapeutic index, that certainly should be a consideration. For capivasertib, we really just haven't seen that very much. So in a patient population, overall, because you have, 4 days on, 3 days off, I haven't dose reduced. I will say that maybe in a patient who had renal insufficiency or was elderly or had a lot of glucose control issues, you certainly could consider this in clinical practice. But I haven't done that quite as much as we have with some of our other agents and chemotherapy drugs in situations where we feel like there's concern about immediate toxicity.
Thank you.
Certainly another option with better side effect profile or slightly different side effect profile. It's always a win-win situation. To sum
Absolutely.
up, as Rahul mentioned in the beginning, in the community, we need to know when and how to use these new novel agents and also get comfortable around managing these side effect profiles. Dr. Rugo, congratulations for this work, which has led to the approval of Capivasertib. Thank you so much for walking us through the study that has established a new treatment option for our patients. For our listeners, let's recap. In this discussion with Dr. Hope Rugo, we covered her study CAPItello-291, which led to the approval of Capivasertib in hormone receptor-positive breast cancer with AKT1, PTEN, and PIK3CA mutations, which are seen in close to 40% cases.
We also got a chance to better appreciate where does capivasertib fall in with all our treatment options that are available today. What are you going to use when you have Elestrin or capivasertib when you see a co-mutation with ESR1 and AKT1, PTEN, or PIK3CA mutation?
Capivasertib got approved on November 16, 2023, and is now part of our standard of care treatment option for metastatic hormone receptor positive breast cancer. Thank you for tuning in. Continue to follow us along for more practice changing data. We are the Oncology Brothers.